Hi, welcome to HealthyU, and this is Dr. Bob Sawyer. I'm going to talk about the importance of rapid treatment of stroke. Want to talk generally about the epidemiology of stroke. It's the fifth leading cause of death, only because we pushed it down from the fourth leading cause of death with our efforts over the past few years. It's about 800,000 deaths per year and a death every 4 minutes from stroke. But more importantly is the profound disability that it causes in people. And this weighs very heavily on the economy and also can change people's lives as they're suddenly shifted around to providing care for their loved one after they've had a stroke. The Gates Vascular Institute, which is the GVI, saw over 1,800 strokes in 2020. This is the most in the state of New York. It's probably top 3 in the country. Our intervention rate, so that's what we do, is we intervene in strokes, is 22%. That means we do thrombectomies or give TPA, and it far exceeds the national norms of 5 to 10%. 36 patients are transferred to the GVI after receiving TPA at an outside ER. And I just want to talk real briefly about the concept of the Gates Vascular Institute. It's a big building that was put together precisely to improve cardiovascular health, and it improves stroke health, cardiac health, and just general vascular health. The advantage is we all mix together. And so we actually have a cardiologist assigned to the stroke team, which is unique as far as I know. And so that type of interaction really helps with stroke care. Okay, if you look at the mortality rates from stroke, you can see that we have the stroke belt down in the south. But if you look at Western New York, which is circled in red, you can kind of see we're a much stronger area for stroke than a lot of areas in New York at all, which accounts for our high rate of stroke locally. So here's our breakdown of diagnosis for strokes. You know, about 85% of it is ischemic strokes, and that's kind of what we saw. We saw a bunch of TIAs, which are really strokes, but they don't leave a mark. Subarachnoid hemorrhages, about 63, intracranial hemorrhages, about 196, and then, you know, there's always some people who have no stroke diagnosis. Okay, so if you look at our acute interventions just for 2020, we did 151 cases where we used TPA. We used endovascular intervention, which is thrombectomy, in 104 times. IV TPA followed by endovascular intervention, which is TPA plus thrombectomy, about 34 cases. And, you know, our total ischemic stroke interventions were 289, which is about 22%. That's pretty impressive. So what are the risk factors for stroke? What you should be looking at? There's one risk factor that's not modifiable, and that's age. You know, we all get older. We all are at more risk for stroke as we get older. But there's a lot of things that we can really kind of intervene on a daily basis. So hypertension, we want to keep our blood pressure less than 130. And in a lot of cases, less than 120 is recommended. Diabetes, we want that hemoglobin A1C less than 7. Tobacco use should be out. And I cannot tell you the damage that the tobacco causes in our population. Dyslipidemias, which is an abnormal lipid panel. It's your cholesterol numbers that are abnormal. It's the LDL cholesterol that makes a difference. Obesity, diet and nutrition. So it's not that people are getting too much food sometimes. It's that our elderly are getting too little food, and that makes you more likely to have a stroke. Physical inactivity is something we can easily correct. Kidney disease, we need to manage as best as possible. Now, there's family history and genetic predisposition, easy for me to say, which can there's not a lot we can do about, but we can manage those things. Associated is atrial fibrillation, heart failure, and atherosclerotic disease. All of those things are treated at the Gates Vascular Institute. Okay, so how do you know you're having a stroke? Well, that's a tough one. It turns out that there's a penalty for being alone. So the part of your body that's being affected is the part you think with. That's your brain. But other people can look at you and see that there's face drooping, arm weakness, speech difficulty, and of course, the last part of FAST is just call 911. Don't wait around for a ride. Don't try and sleep it off. And we'll talk more about this as we go along. Okay, so what do we do to manage acute ischemic stroke? And the reason I'm bringing this up is so that everybody kind of understands what we do, how we do things. So when the patient arrives to the hospital, we'll talk about what they do before they get to the hospital, but when they arrive to the hospital, the patient's triaged. We get some imaging to look for brain and arterial circulation. And the imaging is a surrogate of what's happening at the tissue level. It doesn't tell us exactly what's going on, but it says, hey, this is what we think is going on at the tissue level. And the tissue is deprived of oxygen and nutrients. If you look over at the scan, and in the upper right-hand corner of the scan, that one picture with the red on the it's actually the right side of the brain, but it looks like left to you, is called time to peak. And that's a delay in the blood getting to the brain. And that's critical. The image that I'm showing you has an increased time to peak, which means there's a blockage somewhere. And more importantly, the rest of the scan doesn't show a lot of change. And that's perfect for us. That means we can still salvage that brain. And that's what's so important. So what do we do? Well, for a large vessel occlusion, so that's a big vessel, middle cerebral artery, anterior cerebral artery, carotids, things like that. We use fibrinolytics, which is the TPA, and we send patients to thrombectomy. And we'll talk a little bit more about that as we go along. If it's a disabling stroke, but not a large vessel occlusion, we will use fibrinolytics, which is, of course, alteplase, or we're trying to use tenecteplase. We then provide supportive care, statin drugs, blood pressure control, glucose control, management of any edema in the brain, so that's swelling in the brain, or any bleeding in the brain. And then eventually the patients go to rehabilitation, and it's amazing what rehabilitation can do for these strokes. Okay, but what happens in the cell having a stroke? And that's where I want you to look at the diagram a little bit. But basically, the cell is deprived of the nutrients it needs. And what happens is that cell loses its ability to control its environment. And what that means is the cell can swell up and then almost burst. You get a lot of injury. There's blood-brain barrier dysfunction, and that all leads to cell death, which, of course, leads to cerebral damage. Okay, so what are the logistical considerations to all this? And this is where we kind of get in. I'm just giving you a background so you know what we're trying to do here. So there's two parts of managing a stroke, okay? One, you've got to understand this has happened. You have to recognize the stroke and recognize it as a stroke and then get to the emergency room, okay? And then once we're at the emergency room, we're looking at how fast we can do things safely. So how fast can we get that fibrinolytic drug on board? How fast can we get the thrombectomy done and still do it safely and not cause a lot of hemorrhage into the brain? Okay, this is kind of what the imaging shows you. It's a surrogate for ischemia at the tissue level. And if we look at the acute phase, which is what we're talking about, what we're seeing is change on one part of the MRI scan, and not a lot of change in the CT or some of the other imaging, okay? And I just put that up there just so you kind of see what we kind of understand and what we look at when we look at these strokes. Okay, this is one of my heroes is Jeff Saver, and he's a neurologist out in the West Coast. And you know, I don't want you to memorize this whole chart, but the important thing you need to recognize is that when you have a stroke, you're losing 32,000 neurons a second. Okay, so every single second counts for us. If you have a stroke for about an hour, your brain is aged 4 years. So it's really important that we act as quickly as possible and we do the high value stuff that's possible. Okay, this is what TPA does, and it activates tissue plasminogen. It's a natural analog. There's no allergies to TPA, which is wonderful. But what it does is it activates plasminogen to plasmin, and that dissolves the clot. And that's what we're trying to do. Okay? How good is TPA? Well, if I can get you within 90 minutes, I have to treat 3.6 patients to get one success. If it's longer, I have to treat 4.3 patients. Okay? If I can get you under 4.5 hours, I only have to treat 6 patients to make one better. At 6 hours, it flips. So the number needed to treat goes way up. It's about 19 or 20, and the number needed to harm starts to come down quite a bit. So we want to treat things as quickly as we can. Okay? Now, what do I do if I have a large vessel occlusion? I'm giving the patient TPA, and we get a thrombectomy. Okay? If I can get you within 3 hours, I only need 2.6 patients to treat one successfully. That's impressive. Aspirin's not that good. Surgery's not that good. Nothing's that good. It really makes a big effect on people. And we see these successes here all the time. It's really nice. Okay. These are the 5 New England Journal of Medicine articles and other articles where we had a whole bunch of tests for thrombectomy. And this is thrombectomy trials. And we were seeing how late we could do this thrombectomy and still have successes. And this was put together with the Hermes collaborators. So all those trials are bunched together. And that's what we use to look for what we need. So the number needed to treat in the 0 to 12 hour time window is only 2.6. Okay? And then it lists all the trials underneath. But that's pretty impressive. Okay. Time is brain. So what we look at is we look at the modified Rankin scale. Okay? Most of us are zeros. We walk around with no symptoms at all. We get to do whatever we want. A good result from a stroke is 0 to 1, and that's what we want. And you can see that the percentages of strokes treated, we're looking at a very, probably under 10%, under 15% of the strokes achieve that goal, okay? But a whole lot achieve the 0 to 2 goal. If you have a moderate disability or a more severe disability, we want to minimize those percentages. And what we're seeing is we're seeing that we're increasing the chances of you getting a good recovery go way down as the number goes up. Okay. All right. When we look at the average door to puncture times, okay, so what does that mean? That means the time it takes from the patient reaching the door till the time it takes for them to get an opening into their vascular system to get the wire up inside to fish out that clot, okay? what we're struggling with is that typically these take 81 minutes or 118 minutes, either for direct arrival or patients are transferred from other facilities where we can get more prepared, okay? So each 1 hour delay of reperfusion is associated with a less favorable outcome, but we're struggling with these times and getting the team together, getting the neurosurgeons in, getting the whole team in the middle of the night, and getting the patient up into thrombectomy, where we know we can do a lot of good. Okay, so this picture is my partner Dave Janicki really loves, because it kind of gives you an idea of what happens in triage. It's more like an Indy 500 pit stop than it is anything else. It's sort of controlled chaos, a lot of people moving around. And what do they have to do? Well, they have to do a lot of tasks in a very short period of time. Typically, it takes the patient about 5 minutes in triage before they're moved on to imaging. And during that time, we have to get the history, we have to get a monitor on the patient, we have to get their NIH stroke scale, we start IVs, we get their weight, we get their vital signs, and we notify everybody in the hospital that we have a stroke. Okay? The CT stroke study, which is, we're kind of CT based, has a CT of the head, the CT perfusion, which you saw earlier, and a CT angiogram. And that's all done within 7 minutes. We use a notification system that goes out to everybody and provides the imaging to everybody. And it's called Viz.AI, and it notifies us of large vessel strokes, but also gives us a means to communicate with each other as we're running around. Okay? They get alteplase if eligible. Now, our shortest times are literally no time at all, but it takes alteplase 1 or 2 minutes to get in once we decide to do that. Ideally, we do it on the CT table. And our times, we'll talk about the times, okay? We need a known last known well. We need a normal CT of the head. We need some representation of disability, which is usually the NIH stroke scale, and no contraindications, no bleeding in their head, no recent surgeries, no areas where they can bleed elsewhere, okay? They then go to thrombectomy for large vessel occlusions, and that takes about 90 minutes to pull that off on average, and we're trying to reduce that, okay? And then, of course, there's adjunctive care, and we just take care of the patient, okay? Now, this is kind of an interesting study that we did. We looked at our time to TPA treatment, and you can see back in 2010, we were taking probably a long time just to get TPA on board. And then as we've been moving forward, that time has dropped. And I can show you some averages. Our averages right now are probably 33 minutes on average for everybody. That's for everybody. That means some patients we do in 8 minutes, and other patients it takes us a little bit longer because we can't get a hold of the family or we can't get the information we need to give it. Okay? But contrasted to that, if you look at the symptoms to the door, we've done virtually nothing. So the time it takes for the patient to understand they've had a stroke and get to the emergency room is on the order of 2 or 3 hours. And we haven't made an impact on that. And that's a very tough thing to do. So here's our door to alteplase numbers through 2018. And you can see they're sort of trending down, and they went down as low as about 30 minutes. We've had, with COVID, we've had to change our procedures a little bit, and those times have come up a little bit, but still pretty good. So the last TPA we did it in 21 minutes. Okay, our door to needle times were up around well over 2 hours, and we're, our goal has been 90 minutes, and we're revising that goal because we want that goal to be down around 45 minutes. So about half of what we're doing right now. And how are we going to do that? Well, this I saw the C-arm being put in yesterday. This is supposed to be up and running by June. This is a what's called a 4D CT scanner. It has a C-arm that allows us to do thrombectomies on the CT table. So right now what we're doing is we're taking patients and we're giving them TPA in the CT scanner, and then what we're doing is we're taking them off the table and moving them upstairs to a fourth floor laboratory in the Gates Vascular Institute and treating them, going to thrombectomy. And that's taking too long. So what we've done with a lot of help from volunteers and donations is we've gotten this 4D CT scanner. And what that means is instead of moving that patient, we just keep them right there. And we're hoping that really drops our response times. Okay, what have other people done? Well, in Cleveland, is just an example, what they do is they have a mobile stroke unit, okay? And what they do is as soon as they have a report of a stroke, when you call 911 for a stroke, they don't send out an ambulance to bring you to the hospital. They bring the CT scanner to you. And they can give you TPA right on the table in the back of the ambulance. So that's done before you even reach the hospital. These are very expensive. They cost about $4 million a year to run. And so, that makes them kind of prohibitive. Okay, so in summary, strokes are treated rapidly with alteplase or thrombectomy as soon as after the onset of the stroke as we can. The system of stroke care is important in terms of posture and efficacy. So we have to be thinking in terms of 32,000 neurons a second. We have to think that way. Even if delayed, there is benefit from thrombectomy in large vessel strokes. So sometimes you're able to keep your collaterals and collateral circulation working enough so that if we can get in there and we can do a thrombectomy, we can fix the problem. And that can be delayed to 24 hours, 36 hours, and it depends on how well we manage that stroke. Older and more disabled patients often need the intervention the most. So if you have a patient who's at home, who's in a wheelchair, but they can transfer to a wheelchair, if they have a stroke, now they can't transfer to their wheelchair. And that makes them a whole lot harder to take care of. So we really need to intervene on those patients. Okay? We are constantly looking for ways to speed the process of assessment and treatment to include better identification of stroke, better and safer ways to remove that clot, and also better ways to protect brain vasculature and tissue. So these are neuroprotectants and actually chemicals that we're going to be moving into that actually help the vessel keep from reclotting once we clear it out. So I think we're pretty good on time, and I think everybody who needs to put in a question has probably submitted some questions, and I'd be happy to answer them. So here's a question. It says, is it true that men and women can display different symptoms when having a stroke? Yes. Okay. Men tend not to recognize anything and don't recognize anything in a stroke. They're males. And it requires, some sort of spouse to spot it in them. And that's usually very helpful. So yeah, if you're a man living alone, my experience has been you need some adult supervision. Is there any correlation between those who've had COVID and their risk for stroke? Yes. About 5% of all COVID, what we're finding, 5% of all COVID patients are having strokes. That's incredible. And we're seeing this all the time. So if you haven't gotten vaccinated, get vaccinated, please. If you've had a stroke in the past, do your chances of having another stroke increase? Yes. There was a Oxfordshire study in England, and they said that the risk is about 30%. Okay, you can modify that by modifying your risk factors. Okay, and that's very important. So Mediterranean diet, If you're not drinking, don't start drinking. If you are drinking, have no more than 1 drink a day if you're male or female. Okay. Do all EMS crews know to take potential stroke patients to gates, or is it the family's responsibility to instruct EMS to take the patient to gates? That's a very important question. A lot of EMS crews, so New York state law says they're supposed to take you to the nearest stroke capable facility. Okay, we strongly disable that. We strongly disagree with that. The ambulance will take you to gates, and a lot of times the more savvy crews will just take you to gates anyway. If it were me, I'd come straight here. And obviously I'm biased, but the bottom line is nobody does it better in Western New York. It's just not even funny. So, if they start taking you somewhere else, tell them to take you to gates, and they will do it. They will listen to what the family says. Okay? Since time is everything, is there a stroke team on standby in the ER at all times? Yes. This is probably submitted by Dave Janicki. Okay, I think he's in charge of the neuroscience emergency room, and he probably wanted me to say that. But that's a whole part of the emergency room that's dedicated just to neurosciences. They're on 24/7. We have stroke doctors that are on 24/7, and we're always there. The neurosurgery team, the neuroendovascular team, is here 24/7. So it's really that's really important. I just wanted to end by just telling you a quick story. I had a 93-year-old lady who's out to dinner with her 86-year-old boyfriend, and they're out at dinner, and she keels over with a stroke, and he brings her right here, and brings her in, and we do our thing. So we give her TPA, we do a thrombectomy. She wakes up the next morning, and this happens a lot, and looks at me and saying, "What am I doing here? I want to go home." And I said to her, "Well, not so fast, you cradle robber." And so basically, they're in my office 6 weeks later, and the two of them are there, and the woman looks at me and she says, "Well, what do I do if he's not around?" And I said, "Well, that's easy. Move in together." And they both shook their heads and they said, "No, we're too set in our ways. We're not going to do that." The point is that that somebody spotting you having a stroke is so important, and somebody just being able to recognize that you are having a stroke is really important in terms of getting in here fast. And I think that's it.